Initiative, the London School of Hygiene and Tropical Medicine, the Geneva Center for Education and Research in Humanitarian Action, and the Center for Humanitarian Health at Johns Hopkins Bloomberg School of Public Health. My name is Paul Spiegel. I'm a professor at Johns Hopkins, and I direct the Center for Humanitarian Health. And I have the pleasure to moderate this first session. Before doing so, I want to share with you just some ground rules so hopefully everything can go smoothly. One, please mute all of your audios, and please don't use your videos. If you can turn off your videos, and the reason is just that people are calling in from all over, and we're concerned about bandwidth, although we would love to see you all. For any questions that you may have, please type them in the chat box, and we will do our best to group them into themes, and then we will be asking questions to the speakers. Finally, after the webinar, we'll be sending an email to all participants with a link to the recording, and yes, we are recording, as well as a link to Reddy's discussion forum, because we would like to continue this offline. There are over 500 participants, and so we won't be able to get to everyone's questions, of course, but we would like to continue this. Today's webinar is on shielding high-risk populations against COVID-19. The webinar will present a range of guiding principles for protecting the most vulnerable from COVID infections in a safe and dignified manner until COVID can be controlled, either with vaccine or treatment options when they become available. Our first speaker is Francesco Checchi, a professor of Epidemiology and International Health at the London School of Tropical Medicine and Hygiene, and he will present, followed by David Skinner of Save the Children, and he'll be our respondent from the field. And what we want to do for this series is each time is have someone, a global expert, speak, and then we want to make sure that we have someone who's actually doing the real work in the field give us their feedback. What may be reasonable, what is off the wall, whatever. It's open. This is really meant to share an experience with everyone. So I'll introduce Francesco and then David, and then hand it over to Francesco. Francesco's experience is a mix of humanitarian response, policy, and research gained through work with Médecins Sans Frontières, the World Health Organization, as well as he was the humanitarian health team lead at Save the Children UK. We're followed by David Skinner, and David has worked with Save the Children, where he was a country director for SAVE in Afghanistan and Pakistan, as well as serving as the Global Education Director from 2014 to 18. And David is currently Save the Children's team leader for the Rohingya Response in Cox's Bazar. So with that, Francesco, over to you.
Okay, hello everyone. I hope you can hear me. Okay, I'm just gonna start to share my screen. I'm just asking Paul or Ryan whether my voice is coming across clearly.
Yes, Francesco, we can hear great, thanks.
Okay. And secondly, can you ask my slide?
Yes, we can see your slides as well, thanks.
Okay, so I'm going to kick off with a presentation and just ask you, Ryan or Paul, to interrupt me if for some reason I'm not coming across clearly or my slides are no longer visible. So I'm going to speak for only about 20 minutes, hopefully, and I'm going to start by giving an overview of COVID risks in crisis-affected populations, and then talk more specifically about response options and the concept of shielding high-risk individuals that some of us are beginning to put forward. The current forecast, I should probably, sorry, minimize this. Okay, this is hopefully as best I can get it. All right, so the current forecasts that we have for the world, courtesy of Imperial College a few days ago, paint a pretty grim picture, as you probably you will have seen. one in which basically even in scenarios where we're doing the kinds of lockdowns that that are being put in place in European settings, and even if we carry those lockdowns forward for something like 9 months, we're still facing the prospect of many millions of lost lives. I'm going to move slides. Okay. Right, and just to break this down in terms of what this means in 2 country examples, you have a country like Sudan. They currently have something like 110 intensive care beds. The number of intensive care beds that they would actually need at the peak of the epidemic, if there were no control, would be 56,000, according to Imperial. And even if they did the kind of lockdown that we see over here, that intensive care bed demand would be something on the order of 4,000. On your right, you can see the corresponding figures for Burkina Faso. They are starting with a grand total of 9 intensive care beds throughout the country. So this is basically the scale of the challenge, if you like, at least in terms of hospitalization capacity. And furthermore, the current forecasts that we're seeing, especially when we think about what would happen in displaced populations, other crisis-affected populations, may, on balance, probably reflect more reasons for under than overestimation. So we have some hope, although it's really not necessarily something to count on, that perhaps warmer climate might reduce transmissibility of the virus. We don't yet have any firm evidence of that. In fairly rural places where there is low population mobility and low population density, we have some hope that transmissibility would be lower. But when you look at the models that have been put forward so far, the parameters for these models are mainly based on what we have in China and elsewhere in Europe. And we can very well hypothesize that transmissibility would be higher in crisis settings due to higher household sizes, due to overcrowding, due to inadequate wash. More importantly, or rather moreover, we can also imagine that the risk of progression to severe disease could be higher due to lower biological age and the higher prevalence of comorbidities, uncontrolled and non-communicable diseases, of course, but also TB, which we now know to be a risk factor, and 2 big unknowns so far, HIV and undernutrition. Furthermore, in the absence of any meaningful treatment, by meaningful I mean intensive care, or at least sub-intensive care for some of the patients who can benefit from that, the case fatality ratios could be much higher. So far, the models we're seeing are based on case fatality ratios of mortality that basically reflects a situation in which almost everyone is getting some sort of clinical care. Okay, so Paul Spiegel and colleagues at Hopkins actually did one, I think, what is currently the only attempted forecast for a displaced population, and this concerns the Cox's Bazar Rohingya refugees. Again, you can see here the scale of the problem we are dealing with. In a scenario where transmissibility, here shown in the red curve, is actually higher than what it is in China, and again, as I was saying earlier, it's conceivable that this would be the case. Then you get this very explosive epidemic, where at the peak of the epidemic, your bed, your hospitalization capacity is on the order of 5,000 to 6,000, and this dotted line is showing what the baseline bed capacity is, which is around 340 beds in the Rohingya camps. So, sorry, switching slides. I'm using my wife's Macintosh, and because my laptop is breaking down. So anyway, please forgive me. So what are the possible implications here for health service delivery? It's really an unprecedented situation, I think, to my knowledge, in terms of the kind of pressure that we would see on hospitals. And this would really start in a lot of the populations we are concerned with in a few weeks, potentially 3 to 5 weeks from now. On the bottom, I've also kind of flagged some key findings from the Ebola epidemic in 2014, 2016 in West Africa, which highlights that, in addition to direct mortality attributable to COVID, I think we unfortunately would expect to see quite a bit potentially of indirect mortality due to the fact that general health service provision is at risk of being considerably disrupted. And furthermore, the hospitals, health facilities could really turn into very dangerous environments, not just for patients, but critically for healthcare staff. And we know that there aren't that many to begin with in a lot of the crisis settings that we are working on and in. The little bit of sight that I've had so far and that colleagues of mine have had so far on country strategies, but also, if you like, humanitarian agency strategies, I think suggests to me that generally there's insufficient situational awareness and a full appreciation of how dire things could get. There's an over-reliance on numbers of confirmed cases and deaths. Keep in mind that it has been estimated that a single death of a locally transmitted case essentially equates to about 500 to 1,500 prevalent infections at that time. There's a tendency to react to yesterday's problems, so there's a lot of emphasis on border closures, quarantining travelers. That's really no longer very effective at this stage. And I think also, and I'm referring here in particular to country strategies I've seen, a bit of everything and not enough of anything, by which I mean some attempt to create treatment wards, maybe dozens to hundreds of new beds, reinforcing infection prevention control at health facilities, behavior change, some limited testing and contact tracing that we know to be a major challenge, but not necessarily enough of anything to really potentially have a significant impact on the situation. And if you look at what response options are available, so you've got some leeway on the prevention side. For example, it would probably make a lot of sense to push to at least maintain, if not expand, treatment coverage for comorbidities to make sure, for example, that TB patients are staying on TB treatment, and the same for hypertensives. Asking ill people to self-isolate is certainly useful, although there are a lot of asymptomatics out there who contribute to transmission considerably. So it's not going to be a sufficient measure. The kind of sort of population level distancing and behavior change that falls short of lockdown strategies, promotion of hand washing and the like, that is certainly still a worthwhile thing to do, but it has overall an insufficient effect on transmission by all accounts, and also the adherence, the ability of populations to adopt certain behaviors would really be complicated by where they're living and what they need to do on a daily basis to survive. Then you've got the lockdown option, which is really economically from the education to closing schools for a long time can even lead to poor nutrition among children. So it's really an option that might work in the short term, but it might gain time, but it's not necessarily a very useful option in the longer time period, or indeed a very acceptable option. On the case management side, expanding treatment capacity is, of course, what a lot of European countries are in the business of doing, but I would suggest that in most of the countries that we are worried about, one of the following would be limiting factors, severe limiting factors: beds, clinicians, ventilators, and PPE. And keep in mind as well that the rate at which you need to scale up treatment capacity, given that you're starting from a baseline of very, very, very low numbers of beds, is truly breakneck. You're talking about having to double your bed capacity every 3 to 4 days. And here's a point to be made about marginal increases potentially being more harmful than beneficial. Meaning that if you are only able to expand bed capacity by a little, you will still have an enormous amount of pressure on those few beds, and you might find it extremely difficult to maintain any semblance of quality of standard of care, of care provision within those treatment wards. There's also perhaps an option to think about in terms of home care task shifting, maybe that is applicable more to how to maintain routine health services while all of this is happening. And it's probably worth considering, although it might not have a lot of clinical benefit itself. There are some interventions that I think will not yield much or potentially be harmful. It's kind of the expanding bed capacity without really having the supplies and capacity to actually deliver the kind of care that is needed for COVID patients. I think that isolating non-severe symptomatic cases into dedicated wards, there's quite a bit of talk of doing that as well. It's unlikely to be impactful in terms of transmission reduction because most of those patients will have already spent a good portion of their infectiousness period outside of isolation. And it's going to be a huge logistical effort. And certainly what we know from previous epidemics, I think we're going to have a talk on that in one of the next seminars, is that coercive and top-down militaristic measures will not work. And I think there's a role for the humanitarian community here to advocate for something different. So we come to maybe a last option, which is what we call radical shielding of high-risk populations. What this would be in practice is represented here in these three broad options. One option where you actually have the space to do it is potentially that each household demarcates a room or a shelter for high-risk members and isolates them there. Possibly a more applicable option for crisis settings would be a street or extended family level shielding option, whereby essentially a small group of neighboring households or members of an extended family decide to house swap. They do so voluntarily, but essentially they group their high-risk members into dedicated houses or shelters. And then lastly, a bigger scale option that perhaps might be applicable in some camps, where maybe at the block or sector level, sections are put aside for groups of high-risk people. And this is a paper that I think where we kind of lay out this concept. The idea here is that the approach would be entirely community-led and supported by humanitarian actors. So it wouldn't be a top-down prescriptive approach. The advantages I will show in a second, essentially not resource intensive if it is community-led. It clearly would have an effect of reducing mortality if it is effective. It would relieve health service pressure to some extent. It would keep economies going, which a lockdown cannot do. And it would allow for herd immunity to build within the low risk group. The disadvantages would be that we think it would be only partially effective and that it would not protect that minority of low to moderate risk people who actually, or people who notionally are at low or moderate risk, who then actually turn out to require care. And to be at risk of dying of COVID. But just representing the approach kind of graphically. So in a no intervention scenario, we know that our high risk individuals in the population are only very few, but they account for most of the severe cases and even more of the total deaths. What this approach would do basically is to focus on the high risk, and to try to prevent infection among them, which hopefully would prevent a good portion of severe cases and of deaths in this group. So it's really about maximizing efforts on trying to protect those who we know to be most at risk. Some of the implementation principles would be, again, to not do something that is overly prescriptive. By the way, guys, I'm going to take another 3 minutes most. So not overly prescriptive, allowing for locally appropriate solutions, not necessarily putting up barriers, physical barriers around what we call these green zones. It's almost like an inversion of the way we work in Ebola, where we have the red zone. Here we're suggesting setting up green zones, right, where people can live safely, free from infection. So the idea is that some level of social contact would still be possible, but for example, you would establish a single entry-exit point with very stringent infection control. Another important principle would be that residents care for themselves as much as possible. That's because you would want to avoid introducing too many people from outside into these dedicated areas, these shielded communities. we think they could be managed by social care committees of some sort, perhaps supported by community health workers, by the Red Cross, by other civil society groups, depending on the local configuration of who's doing what. Clearly, residents would need to receive support. And this is, I think, where humanitarian actors could really make the difference. Water, of course, food and commodities, but also critically mobile outpatient treatment, not necessarily for COVID itself, but for example, to refill prescriptions, to make sure that chronic conditions are managed. And that's basically to avoid people having to leave their green zones. So these are results from yesterday that are very, very preliminary, but we're doing mathematical modeling here at the London School. This is work that my colleague Kevin van Zandvoort has rather amazingly led over just a few days. I hope he's taking a break today. But essentially, what this is showing you is the potential that this approach may have. So we ended up modeling 3 representative African countries. This is at the country level. You know, for example, the way to read this table is if I implement my shielding approach for 9 months, sorry, these percentages are typos, that's 9 months, and I'm able to shield 80% of my high-risk population, and I am able to reduce contacts between that high-risk population and the low-risk population by another 80%. So that's 80% times 80%, if you like, in terms of the reduction in exposure of the high-risk group. Then I would expect to reduce my cases requiring hospitalization by 60%, for example. And if we are able to achieve something even better than that, then we would be looking at maybe a reduction in bed requirements of 70 to 80%. I should stress we haven't yet done the maths, if you like, for expected reductions in mortality, because there are a lot of assumptions that we need to make that are a bit sensitive. But generally, we would expect mathematically that the reduction in mortality would, if anything, be higher rather than lower than these effects I'm showing here. So just to conclude, this is essentially the main approach we are suggesting at present. It's not to say that this is the only thing that's worth doing, by no means. I think it's also, you know, an attempt to maybe inject a practical idea out there, but it doesn't mean that there aren't better approaches. We are currently finishing up technical guidance, at least version 1, for camp-like settings for how to implement this. We'll then move to urban and rural scenarios. I mentioned the mathematical modeling that's going to be fleshed out a lot more in the next few days. In the pipeline, also looking at other aspects of the humanitarian sort of response to COVID. We're planning to do something around actually can manage cases, some guidance on surveillance, and maybe also look at 3-tier shielding options where you recognize that there is a moderate risk group that may need to be protected as well. And maybe you can do something for those moderate risk individuals. Lastly, if you want to get in touch, we're all ears. We can try to help and support. We are already in touch with a number of humanitarian actors. And I would ask that you email Caroline in the first instance, and we will hopefully try to get in back to you as quickly as we can. I'm going to leave it here. Hopefully the presentation was reasonably audible, and thank you so much to Hopkins and all the other colleagues and all of you for listening.
Okay, hi everyone. Francesco, if you can stop sharing. Okay, we're going to move now to, firstly, thank you very much. There's been a very active back and forth already on the chat. So David, I see you. Over to you, David, for your comments, and thank you very much.
No, my pleasure. Hi, I'm David Skinner. I'm the team leader for Save the Children on the Rohingya Response. And I should start by saying thank you to Johns Hopkins and others who set this up. I think it's very important that we are sharing our understanding and our experience at this stage. You had a bit of a background in Francesco's very good presentation about the camps in Cox's Bazar. We've got 850,000 refugees plus host community in the environs. There's a humanitarian infrastructure in place already, so we have advantages there. We're in Bangladesh, which is has just become a low middle-income country, so it has better infrastructure than many places. Francesco talked about some of the Johns Hopkins modelling that's been done. That was on part of the camp, so it didn't include the entire camp, it didn't include the host community, and as Francesco said, it used data from China, which actually came out with a lower mortality rate for the camps than China, because the demography is different. People are younger in the camps than they are in China. Even so, it was coming up with forecast deaths of between 1,647 and 2,109. Other modelling has looked at what the demand is going to be for beds at the peak week during the outbreak. That is likely to be, if everything goes extremely well, 5,000 beds, but it could be up to 12,000 or higher beds that are going to be needed at the peak. At the moment, we've got 350 beds across the response. We're working hard to try to increase that, but it's not easy to put new treatment centres in place. We think we may be extraordinarily fortunate to get it up to 1,500, but we're looking at a significant gap in the provision of treatment centres. So I think that the initiative to look at alternative ways of managing the response, managing the outbreak, is essential. And I think we need to acknowledge that it is absolutely going to be the case that the community are going to be managing a large proportion of the cases. With the best will in the world in the Rohingya response, we're not going to be able to do everything, and there will be times, I fear, when we will be when demand will be much higher than supply. So the ideas about shielding are interesting, and I think we need to take them seriously. I think they do raise certain questions, and I'd like to just go through the three different options that Francesco put forward, just to give some initial thoughts. So the suggestion of creating a standalone largish site to shield the vulnerable, I think would be complex culturally. I think it'd be conscious. It'll be complex politically and socially, and I think it could be quite dangerous. I mean, if we were not able to keep infection out of the population, then it could be catastrophic. If infection were to be able to get into the vulnerable group in a larger area. I think shielding in-house, in the shelter in the Rohingya camps, would be pretty much impossible. The shelters are small, social distancing would be a problem. People have to leave the house to get water, have to leave the house to get food. We're going into the cyclone and monsoon season, so I think that being able to protect individual vulnerable people inside the shelter would be very difficult. Sort of block level, or I think Francesco referred to it as street level shielding, is intuitively more likely, and within the camps, as it happens, because of the lockdown, we've got various unused facilities. So the schools are not being used at the moment. The child-friendly spaces, the girl-friendly spaces, the older people's friendly spaces are empty, and all of those have got wash facilities, have got latrines, have got water. and all actually have a boundary. So there's a possibility that that might happen. I think you run into some of the same difficulties that you would about having a large space. I also trying to imagine what the situation's going to be like, and when the community are self-managing the response, I think the instinct of the community will be to use those facilities as treatment centres, as community treatment centres, rather than as using them as green zones or as shielding spaces. Now that's so, and I think that would be the natural instinct of the community. So to change it would be possible, but I think it would require a lot of intense communication at this stage over the course of the next few weeks, and I worry the degree to which it would be effective. And I think that is essentially my last point. As has been said, this is going to have to be done at soon. I mean, we're talking about and I assume we're talking about an outbreak occurring in one of the countries where we're working in over the course of the next month, maybe the course of the next 2 months. Being able to do the kind of information and communications activities to explain about shielding and how it works, I think would be tough. I don't think it's impossible, but I think it would be tough. So those are some of my initial thoughts. I think it's an important idea. I think it's essential that we are looking at different options, because our traditional responses are simply not going to be adequate. But I think there are some challenges with the with shielding in practice in Cox's Bazar. It may work more effectively elsewhere. We may be able to make it work in Cox's Bazar. I don't think it would be straightforward to do it. Thank you.
Thank you very much. Thank you very much, David. I have a bunch, there's been a lot of discussion as everyone has been speaking. So I'm going to try to summarize just a little bit and then ask some of the key questions. There is certainly some criticism of the concept in terms of what David was discussing. What number one is the cultural acceptability. How do we get buy-in from the people? And that's going to vary by culture. So I don't think we're talking obviously just Cox's Bazar and Rohingya refugees. It was mentioned that it was discussed at the Global Health Cluster meeting in Cox's Bazar, and the idea was rejected. There are a lot of other questions that we will get to in the near future, so we won't talk about specifically we can talk about WASH, but there was something about treatment and bed capacity. Francesco, you can feel free. So some of the questions that specifically over to Francesco would be, okay, one is in those situations, how do we increase although I said I wouldn't talk about water, I'll mention specifically if you're going to be shielding certain people with limited water conditions, how do you arrange for water how can water be sufficient for those people and not potentially other people if you have limited water supply? Secondly, a question about, it's really more about treatment, but how are you going to, in terms of shielding, how do you survey these people to make sure that they're not infectious when we know that there is transmission before symptoms? And then the concern that once infection gets amongst those people who are isolated, i.e. like a nursing home, it could spread, like someone said, wildfire. So how do we address that? Again, a question, but David was hinting at this, is how do we do shielding in very, very poorly housed conditions like slums, or I guess in the Rohingya setting. Couple more and then I'll stop. How do we establish a criteria for whom to shield? Because age is not just a straightforward case, and I believe, Francesco, you were talking about age and also those that may have medical conditions. I think I'm going to stop there for the moment and hand over to Francesco, but just to say on an admin note that We are, the READY Consortium, who's helping arrange all of this and working with us, is going to try to amend the call platform for over 500 participants in the future. Hopefully that won't affect bandwidth. So Francesco, over to you, and it'd be great to see you if you want to put on your video.
Okay, hi everyone. You can see that I exist. Yeah, I have a bad internet connection. That's why I was avoiding the video. Also, you can't get haircuts anymore. Anyway, a lot of very good questions. I should really stress that you know, this is a concept, and that some of the doubts and challenges that have been expressed and that I'm also reading on the chat are entirely fair. And you know, our point of view is basically that we can support actors to explore this, to put this in place. We can provide a lot of the technical input, but that ultimately, you know, we need that sort of ground truth to prevail and determine whether this is the right idea or not. I would, however, say, particularly if we are looking at a camp setting, but not only, the attack rates are going to be huge. Okay, they are going to be, you know, if you look at the UK without any control, it would be on the order of 60 to 65%. So in a camp, it's going to be more than that. What I would encourage everyone to try to answer for themselves is, if not this, then what? If not this, then what? Something needs to be done, but I'm afraid that the strategy of increasing bed capacity is just not going to fly for nearly all crisis-affected settings. The mountain to climb is just way too steep. Is way too steep. If there's anything else that can help on the prevention side that isn't a lockdown, then by all means, let's explore it. Anyway, so in terms of limited water supply, well, I mean, this again goes to my point. You know, if you have a situation where you have very limited water supply, then essentially it's going to be extremely difficult to do the kind of general population level prevention that you know, you to try hand washing with water. I would say that in such a setting, you would want to basically establish green zones and provide them with enough water, even if it means reducing water availability for everyone else. But keep in mind that we're not talking about a very large portion of the population. We are talking about potentially something on the order of 10 to 15%. In terms of surveillance, we were thinking that this would be syndromic, and that basically anyone who has sort of the classic syndrome symptoms of COVID would basically immediately self-isolate. So a better design would be one in which at least one shelter in the green zone is set aside for self-isolation of symptomatic cases. Where possible, then these people would get tested and taken out if they are infected. That so far is really the only realistic solution we have thought about in terms of that. The way this would work in slums, well, again, in a slum, you would expect an extremely high attack rate. So I would again challenge everyone to think about what else would work and that would, or what else would work better. But essentially, it is very much a question of risk perception, I think, and people perhaps needing to understand or being helped to understand how much of a threat this really is to their families, to their communities. And then, you know, who knows what is possible once people actually see danger ahead. But it would what I need to stress is that this needs to be very, very radical. It needs to be very radical, meaning people need to be closed in, be isolated physically for a long period of time. In a slum, you know, it doesn't matter how cramped things get, but it means that essentially some families would relocate from their very small shelters, very small kind of one single room housing, and leave that space for high risk populations, and then close the door. And yes, there can be some social contact so that people don't feel terribly lonely. And of course, yes, these people need to be resupplied with everything they need. But I don't think much more contact than that is really allowable if we are to see this approach work in any way. In terms of the criteria, we are working on that, but essentially, I think 60 years plus, and some of the non-communicable diseases that we know about: hypertension, diabetes, cancer, chronic obstructive pulmonary disease are the main four, I think, and TB. But TB would require a different form of isolation, quite frankly. You couldn't possibly, I think, essentially group TB, people with active TB with other high-risk individuals. We don't know yet about HIV and malnutrition. So far, I think we would leave. We would put HIV in because I think it's plausible to assume that they would be at higher risk. I think malnutrition is still an unknown.
Okay, thank you, Francesco. We're going to get to some other questions, and I see a lot coming up already here. But David Skinner, do you have anything to add?
Not really. I mean, but I do think that Francesco is asking a question. Then what? So we're looking at a very difficult circumstance where communities are going to be stressed very heavily and are going to be looking for some form of support. And whatever it is that we think is the best solution, we need to be talking about it now. I continue to have my worries about shielding, and Francesco's been articulating some of them. I don't have a good alternative at this stage. I'm not quite sure what else it is we would do. It's essentially we would need to be providing support to communities to look after sick people, and they're not equipped to do that. So I don't know what the alternative is.
Okay, thank you. Francesco, just seeing and reading some others, and I'm sure a lot of people are reading it. Number one is talking about the guidance and what guidance are you planning and when will it be released? But I see that there's still a tremendous amount of skepticism in a couple other areas. Number one is that in areas where there's high poverty and in slum-like conditions, by doing this, there needs to be some sort of economic support, or you can't expect, one cannot expect people who are living day by day to just accept isolation without provisions of food and other aspects. So it could be quite costly. And then there's still concern, particularly because at this point, since there's insufficient testing across the board, and because more and more data are coming out showing that people maybe up to even 30 or 40% are asymptomatic but still able to spread. But by putting these people together, even if it's at within smaller zones, it could have a nursing home-like effect. And let me see if there's anything else to do. Yeah, and then there's talks about the issue of malnutrition, and there are, I guess, one of the big issues, and we've been grappling with, is even though in our modeling in the Rohingya, proportionally the amount of deaths just by using the Chinese model was lower. Again, that's proportionally because of the younger age distribution of the Rohingya. We didn't have sufficient data to be able to take into account the underlying issues, and in particular acute malnutrition. So maybe over to you, Francesco.
Okay, sure. I'm going to stop my video because my internet is not great. So All right, so we should be able to release somehow a pretty short document, about 10 pages of technical guidance for how this would be done in a camp setting. And then we will move on to an urban, say, slum setting, and then a rural setting. I think maybe, Paul, through kind of the platform that we're putting together, we can see how best to upload that guidance, and anyone else is just welcome to contact us as well. In settings of high poverty, this would, of course, have challenges, but keep in mind that the measures that otherwise will need to be put in place, such as lockdowns or other forms of social distancing, also have very serious economic implications. I actually think that in this case, we are saying no, allow the lower risk, mainly working age population to stay in work, potentially allow also children to stay at school, and help those who are either no longer economically active or who still are but can perhaps be spared from working, help them to survive. I was talking to the World Bank about this yesterday and kind of made a similar point. So there are a number of financial instruments or cash-based transfer approaches that I think can be leveraged, I think, to help both the shielded people, but also those caring for them. In any case, we're heading down, I think, if you talk to any economists, a bad track when it comes to the economic situation in these countries, and it's not going to be helped by countries becoming completely isolated or slowing down their economy to a standstill. In terms of the asymptomatics, so we think that, first of all, the approach should be undertaken soon, before widespread transmission starts in a given location, so that hopefully those who are entering the green zones are by and large not infected. Moreover, if somebody is ill or is in a family, in a household that has symptomatics, then they should wait the usual customary period until all sort of symptomatic disease has resolved and a bit more, before joining one of the green zones. This will be in our guidance. I think a game changer potentially could be serology, so the availability of the serological test that tells you whether you've been infected already, because then you could potentially start to think about other configurations where, the people who are helping kind of high risk individuals, so people around them, can be specifically those who have already been infected, and you could actually go for some sort of shielding, as the term really suggests, which is surrounding your high risk groups with some sort of shield of immune people. It's not really the same concept as a nursing home, I have to stress. I know that nursing homes in Europe have been very, very problematic in terms of COVID transmission. But what we're saying here is no, we wouldn't have outsiders come in. We wouldn't have any outsiders come in, or perhaps you would have one or two carers who are kind of isolated with the shielded population from the start. We would want basically these groups of individuals to care for themselves as much as possible, knowing that there will be some who are not so able, some who are still physically fit. That's the concept. The idea is not to have a large group of clinicians or carers coexisting with these high-risk individuals.
Okay, great. Thank you. Yeah, there's been clearly a lot of discussion. I mean, firstly, a big thank you, Francesco and colleagues, Maysoon Dahab and others who are bringing this up, because we do need to explore other options, and we need to be able to look at it. It's a tough line, because we obviously want to do no harm. On the other hand, the current situation, if it can be improved, we need to be able to take some of these risks. But it is I would say, ethically fraught, depending on what does happen. But we need to, I think, and I think everyone would agree, we need to think differently and try different responses, and this certainly is one of them. We hope in the future we're going to be looking at, in this series of which London School and Sarah and Reddy and ourselves are a part, we want to be exploring other areas, everything from looking at how can we, what Francesco mentioned in terms of, great, we're going to expand dramatically our beds, but if we don't really have much treatment to offer those that are severely sick, what does that mean, and other options. We hope to, and we are aware that there's a lot of there is some guidance out there with from the World Food Program looking at mass distributions and possible effects there. So looking around still, and I think at this point we should slowly close. There's still a tremendous amount of discussion going on, and so I think that's great, because it does show that that people are thinking about different options. We have sent, and we will send again, maybe Ryan or Aileen, you can put again the discussion forum website. On that forum, the Ready Discussion Forum, we will put Francesco's presentation. I see people are asking. We will also shortly, we have to put it onto a YouTube link, etc., but we will provide a recording of this video to everyone. On that discussion forum, and in the future, we're going to be doing this week by week, every week, Wednesday from again for Eastern Standard Time, 8 o'clock till 9 o'clock, and that translates into your time zones. We will shortly be announcing the next one. We just need to confirm. We're also, perhaps on the discussion forum, it may be easier to add other ideas that you'd like to hear. I've read some in terms of disability. And we appreciate everyone. There's been a huge over 500 people, and then we had to stop because of that was the limit. We are, as I mentioned, trying to change this limit in the future, with the hope that bandwidth is not going to have a major effect on the transmission and the speakers. And again, the forum will be having a global technical expert speak, and then we will try to always have someone from the field give their views. It's meant to be just like it is today, for us to be discussing different ways to do things and then getting pushback, having thought. It's really meant to be open and constructive, and I do appreciate everyone's tone here of pushing back if you don't agree, but always being respectful. So that's been extremely useful. Francesco and then David, any last thoughts or points from you?
Maybe. No, this has been really helpful for me and my colleagues as well, to kind of stress test some of the ideas. I think if there were any way to kind of preserve some of the sort of the questions and chats that have been posted, that would be really, really precious for us to kind of capture some of the feedback. I would just stress that we really need some very targeted strategies very fast for these settings. We have 2-3 weeks at most to really put something in place that catches the curve before it takes off. So I know it's really, really challenging, but anyway, I'm sure I'm speaking for Paul and Carl and some of the others. I'm sure most academics at this stage would say, you know, reach out to us if you think we can do anything. Thanks again.
Thank you very much, Francesco, and also for pushing the envelope. It's hugely important. David, anything on your side?
Just to say again, thank you very much to you all for pulling this together. I think we are facing an enormously complex and difficult challenge in a very short period of time, and getting support from academics is enormously helpful. You're helping people think through what the issues are. I think it's also, for me, one of the things I've appreciated about this call is the sense that there is a community of people around the world trying to think very hard about how to solve an extraordinarily difficult question. And so I'd like to also acknowledge all the people from across the world who've been in the chat box, raising questions and thinking about how we're going to manage this. We're going to get our best ideas out as a result of that. So,
great. Thank you, David. So we will end, just because people are still asking. The presentation and the recording will be shared. This discussion forum. I mean, one of the big areas that both the READY Consortium, which is made to look at preparedness particularly for NGOs, Carl Blanchet and Sarah and Francesco AL at London School and ourselves at Hopkins, what we've been doing is we've been speaking individually to many NGOs and others, trying to at least work with them, give some thoughts back and forth. But what would be great is to have some sort of platform, and we're working on this, and we'll try to come out with something very soon, where we'll provide at least areas and ideas and some principles. But what's essential, I think, is that people are not waiting for us, obviously, and all the NGOs that we're speaking with at ground level, at field level, are already trying different program adaptation, and we need to be able to record this and share this with everyone, both positive and negative, so that we can all learn. So that is one of the goals of this webinar, and one of the goals of a platform that we're trying to develop to be able to move this forward. And as we talked about, some of the ideas will be surveillance, some of it will be how to do treatment in austere conditions when you clearly won't have enough ventilators, respirators. Carl Blanchet is looking at prioritization, looking at some health checklists. So we're trying to put it all together on one platform, and we would be very, very happy. And I know people who are listening who are in the field are so busy, but if they can share with us their experiences, I think we could all benefit, and then we can try to put them all together and try to interpret them. So again, thank you everyone very much. It looks like it's been a successful webinar, and we very much appreciate it. Have a good rest of the day, and please stay safe. Bye-bye.
Thanks, everyone. Just to say, the webinar recording and continuing conversation, we sent the link in the chat box, and we'll share it right after this call. Thanks very much. Bye.